Our next speaker is Sigurd Berven. Dr. Berven is professor of orthopedic surgery at UCSF and chief of our division.
Well, thanks, Lionel, and thanks for the opportunity to participate this year. Again, Srini, that was a terrific overview, and I think your insight into the history of idiopathic scoliosis and how we treat it really is important for us all to understand, and really standing on the shoulders of giants is how we make further progress. One of the things that's really special about this course, and I think valuable about this course, is indeed the combination of pediatric perspectives as well as adult perspectives. And just by show of hands, how many people in this audience are actually actively treating pediatric patients? So I think, and the combination of what we learned from our pediatric experience and our adult experience is the basis of the SRS. Right now more than half the papers of the SRS are actually on adult deformity, and certainly the population is much greater there. But we learn a lot from, I think, the cross-fertilization and the few practices that really expand both, or span both the pediatric and adult population. And one of the perspectives I think that's valuable is the notion that, if you're working in a purely pediatric hospital, then you think, oh, when this patient turns 18, I'm no longer going to see this patient anymore, and therefore I've got to do something before they turn 18. But being accessible across the continuum, I think, really leads to a very different perspective on when different disorders need to be treated. And I'll preface some of my comments by saying I think that a lot of relatively benign conditions might be overtreated, and in a lot of instances might be better off left into adulthood and observed over time. And I'll specifically, what I'm going to address now in my 20 minutes or so is the notion of what are some of the deformities that really we ought to recognize in childhood and treat early, and the corollary being what are some things that maybe we should wait into adulthood on. Just in terms of disclosures, I'm a board member for the North American Spine Society, so I don't do any active consultancies or receive any honoraria right now. So I think deformity in the pediatric spine is distinct from adult deformity, and there's different curve patterns in the pediatric population. The clinical symptoms are different, right? In the adult, we're generally dealing with present disability, present functional limitations, and the natural history is very different in a growing spine compared to a mature spine. And the goals are different, right? In the adult, we're trying to improve health-related quality of life. We're trying to improve present disability, present functional limitations, present pain. In the child, really what we're trying to do is avoid future disability. And for those of you who are interested in healthcare economics, we can quantify that with quality-adjusted life years, which is a good measure for present health status or present self-assessment of health status, as opposed to a disability-adjusted life year, which really gives us more of a lifetime perspective on health status. And there certainly are some advantages to early surgical intervention, but there are also some risks that we face. And then there are some risks and advantages to what we ought to observe into adulthood. And fundamentally, what we want to do is try and empower informed decision-making. And these informed decision-making process has to take into account patient values and patient and family preferences as well. So pediatric deformity really encompasses a broad spectrum of pathologies, and we've got our congenital pathologies, and characteristically these involve failures of formation or failures of segmentation with variable rates of progression depending on the pattern. There's neuromuscular pathologies, syndromic type pathologies, as a patient with neurofibromatosis we might talk about a bit later in cases. And then idiopathic deformity, certainly most commonly, is a patient who develops an asymmetry of the spine that's of unknown etiology. And then also, I think, recognizing the sagittal plane malalignments or Sherman's type kyphosis and spondylolisthesis. And one of Sharina mentioned John Hall as one of the founding members of the SRS, and he, along with Serena and David Bradford and others, were some of my most important mentors. And John Hall has a lot of quotes, they're mostly quite brief, and some of them are quite rude. But one of them that I can repeat is that the decision of whether or not to operate is far more important than the decision of how to do the surgery. And the notion of when to operate really being such an important part of our decision-making process. And And John Hall was a real master surgeon. He was, you just don't see this anymore. Maybe some of you do, but he was the best foot and ankle surgeon. He was the best hip surgeon. He was the best spine surgeon at Boston Children's Hospital. And we get so subspecialized now, but he was really a special fella. Another one of his, he talked a lot about sagittal alignment, and we've done so much research now, and Chris Ames and others doing a lot of work on how we classify the sagittal plane. And he said, Sig, it's really pretty simple. You just got to have the E hole over the A hole. And so here's really simplifying things, and maybe we make things too complex sometimes. So when should we operate on the adolescent? We need to know about the natural history. The clinical presentation is certainly important, and when should we observe things into adulthood, and that gap is important. And timing, we'd certainly rather operate, for example, a patient with a spondylolisthesis with a relatively low-grade spondylolisthesis before they develop a high slip angle, before they develop neurologic complications is much easier. Or the patient with a deformity. So, for example, if somebody with a simple 1C deformity, wouldn't it be better to try and capture that and affect the natural history of that lumbar curve before they develop into a structural type of a lumbar deformity? And perspective is an important part of this. So you got the perspective of the patient. Oftentimes, many of our adolescents tend to be a bit disengaged about this, but their perspective is important. The parent tends to be a very loud voice in this conversation, and obviously the physician's perspective. And sometimes you need to look from different perspectives between the adult and the child. So, adults have surgery for scoliosis primarily because of present pain, present disability, functional limitations, neural involvement. And the concern for future consequences isn't always a big part of the conversation. So, for example, this is a 58-year-old woman who has a lumbar degenerative scoliosis, and she's actually a naturalist and does a lot of work in both Hawaii as well as Alaska. And she developed progressive pain, some difficulty with walking, but her real concern is at this point she was 58 and very healthy, and she said, Doc, what I'm really worried about is what's going to happen 10 years from now when I'm 68 and I won't have the same level of bone density, I won't have the same health. And this is something that we see quite often, probably more often in older people. I'm 70 years old now and I'm healthy, but and I'm getting by. So what's going to happen 10 years from now in terms of future consequences? And my standard answer there is I can't make asymptomatic any better. So we ended up actually watching her for about 10 years, and then when she was 68 years old, ended up doing this reconstruction front to back to get her aligned, but not until she had significant disability, because on average, these patients of a multi-level reconstruction really aren't going to be climbing mountains in Alaska, and are, on average are going to be taking non-narcotic medications on a daily basis, and have some limitations to their activity. Well, what about the adolescents? So why do children choose to have surgery? And this was a study by Tom Lowe and others. And in children, it's very much concerned about the future consequences. And we heard about this earlier. Appearance is part of it. And present pain, present function really isn't as much of a priority as it is in the adult. When we think about our goals of care, we want to correct the deformity, and importantly, we want to prevent progression of deformity. We do want to improve health status. And another important goal is the future consequences of the deformity progression. So as you heard about this earlier, is what are the consequences of the deformity progression? Well, there's cardiopulmonary problems. There's significant differences in mortality for a subset of patients, neural impairment, pain, disability. And we can think about all the domains that make up health-related quality of life. So when we're counseling and making informed choices with our pediatric population, we really want to know more about the natural history of these conditions. And looking back on some of the early research that was done in this Alf Nackhamson and others, and this was referred to earlier, looked at patients with long-term follow-up of untreated scoliosis. And this is really quite shocking to see the observed death rate compared to the expected death rate, and suggested that patients with scoliosis, indeed children in long-term follow-up, die earlier when we look at their mortality. But having said that, when you really break it down, it's important to understand the difference, is that it's really the patients with the early onset scoliosis, right? So infantile and juvenile scoliosis who have a much less benign natural history than our adolescents, who in fact have a mortality rate that matches what we'd expect for unaffected people. And obviously the severity of the scoliosis being what determines early mortality and disability. And that led to, as you heard earlier, a very nice talk on early onset scoliosis, this notion that we really need to look at the age of onset of deformity and the etiology. So our congenital curves, our neuromuscular curves, our syndromic curves are going to behave very differently than our late onset idiopathic curves. The magnitude of the deformity, both in the coronal plane as well as the sagittal plane, is going to be part of the natural history. And recognizing the rate of progression, especially in the growing spine, and that these are the variables that really go into our decision-making about early onset scoliosis. And again, recognizing that the natural history of the patient with early onset scoliosis is very different than a patient with late onset scoliosis. So the group in Iowa, led by Stu Einstein, took a look at 50-year follow-up of patients who had a late onset of idiopathic scoliosis, and found that really untreated late idiopathic scoliosis, these patients were quite productive. They functioned at a high level, even 50 years after the diagnosis. And untreated late onset scoliosis had very little physical impairment other than some back pain and some cosmetic concerns compared to patients who were unaffected by scoliosis. Yet with this as a background, we've also got a bit of a contrast, because we also know that adults with spinal deformity present with more disability and with more functional limitations than many other common medical conditions. And we studied this early on. One of the better studies on this was done by the European Spine Study Group led by Ferran Pellicer. And they showed that adults with symptomatic scoliosis had more physical function impairment, their role physical, bodily pain, general health, vitality, social function, role emotional, mental health. In each of these domains, patients who are surgical candidates for adult deformity, in fact, had a worse health status than lots of other common conditions, so worse than patients with congestive heart failure, or chronic lung disease, or osteoarthritis of the hip and knee. So there is a subset of patients who certainly are symptomatic in adulthood. So recognizing that subset, and if we can find out who those are, well, that's a subset maybe we ought to be treating earlier. So who reliably then, just giving you some examples, should we treat early? So this is a patient of mine. He was a 12-year-old boy when I met him, and he's got, you'll recognize here, a hemivertebra. I thought I was going to show you a CT scan next, but he's got a hemivertebra at L5. He's got a contralateral bar on this left side. He's had a rapid progression of his lumbar sacral curve. And in this instance, Mike McMaster had written rather extensively about this, recognizing that the hemivertebra with a contralateral bar has got a particularly malignant natural history in terms of progression deformity. So this is somebody where I basically did a posterior-based hemivertebra excision, put a cage on the opposite side, essentially trying to level the L4, and that we expect that this should lead to an improvement of the natural history of this upper thoracic curve. And I've followed him until about age 18, and there was no further progression of that thoracolumbar curve. So treating this early as opposed to allowing that lumbar curve to become structural is clearly a good example of where we might be able to improve the natural history. This is just another example of a patient with a hemivertebra, again, in this case in the mid-lumbar spine, a patient with some progression of her lumbar curve, and CT scan shows that characteristic posterolateral hemivertebra, and in this case, doing a hemivertebra excision with a relatively short posterior-based fusion allows us to get some correction in the coronal plane as well as the sagittal plane, and again, no further progression with a short fusion in this case. Here's perhaps a more concerning example of a patient with a type 1 congenital kyphosis. So this is a patient who I had access to their outside films. I met the patient here in 2014 with a relatively severe thoracolumbar kyphosis. And this pattern of kyphosis is type 1 hemivertebra with a incarcerated hemivertebra extruded posteriorly, can cause a significant neurologic deficit. You see here the compression on the conus by the hemivertebra. And this was the case, the group that I trained with, Kim was a resident with me in Boston with John Emmons and Tim Oresco and John Hall and the group in Boston. And they showed that these patients with the type 1 congenital kyphosis really tended to have a very high rate of progressive neurologic deficit if left untreated. And this person actually, this child had surgery at the National Children's Hospital in DC, and they tried to just do a decompression with an onlay fusion, had progressive deformity, neurologic progression, We made it out to San Francisco where we did a posterior-based approach, excised the hemivertebra. Oftentimes in these cases, this can be actually more difficult in a child to do than the adult because the tissue is kind of cartilaginous and it's a little more difficult to excise an osteoporotic bone. That's one of the nice things about osteoporosis, or even patients who've got cement in their bones. It's very easy to take the bone out. In kids, this can be very difficult. I'm looking to Lionel a little bit, and we've done a few of these cases too. And so anyway, we took out the hemivertebra from the back and got a nice correction, a dramatic improvement of his deformity. And I thought I was going to show you a picture of him. Somehow that didn't get in there. But there's a picture of him now. He's kind of a surly 16-year-old who plays hockey. But his mother's very appreciative. He doesn't really remember much of the episode, but he's a hockey-playing 16-year-old from Los Angeles now. So what about in scoliosis? Or what about in other types of deformities? I think that there are some deformity types that maybe would be better left into adulthood. Here's an example of a difficult deformity. This is a patient who's got a lanky 3CN curve, and she really has no pain, no limitations. She's actually a scholarship athlete to USC. So she came to see me at age 17, and at the end of her high school, and she was a high school champion for California, was going to run the 400-meter hurdles at USC, and wanted to know if she ought to have her scoliosis taken care of. And my answer here was that, in the absence of pain or instability, just because you're 17 years old doesn't mean that this needs to be taken care of now. And I said, you're skeleton mature, and let's see how this evolves over time. And she ended up going through her junior year of college, did well with her sport. And I point this out because this is a difficult type of deformity because the progression of these 3C curves can be quite significant, especially when there's a lot of rotation in a lumbar spine. And one of the issues about, when do we wait into adulthood, is this study suggested that in younger patients, we get better curve correction. There might be some lower risk of junctional pathology, but overall, no difference in outcomes. So again, we ended up observing her into her end of her college. And at that time, she actually felt that her symptoms were getting worse. She was really bothered by the deformity. So we treated the thoracic curve and got some derotation to the lumbar curve. Now, the trouble with these curves can be that the natural history of this can be difficult. So here's another case of a 14-year-old who's had some progression of her thoracic curve. And again, treating the thoracic curve, I think we can improve the natural history of that lumbar deformity. But if we look at this, and John Webb had looked at this, more than a quarter of these patients actually, when you try and spare that lumbar curve, may have significant progression of deformity requiring further surgery. So we really need to be careful about that subset of patients. Here's a more severe example of a patient with a 4C curve. So in this case, the lumbar curve is bigger than the thoracic curve. And in this instance, again, a long fusion down to L3 involves a lot of morbidity and a lot of possibility for junctional problems. So the question becomes, when should we observe this into adulthood? And here's another example, a girl who's skeleton mature. She's 2 years after her menarche. She's a dancer. She's a volleyball player. She's got a double major curve, lumbar being greater than the thoracic, but overall really mild symptoms. And this is somebody who I said, I don't think you'd be better off with surgery, because if we did surgery, we'd end up doing a fusion down to L4, and really that would involve significant disability. And just give this as an example of what might happen. Well, what might happen indeed is this curve may progress into adulthood, and this is obviously a different patient. But this is a 36-year-old woman I treated some time ago. She works as a laboratory technician, has a master's degree, and mother of 2 young children. And she had a similar curve to this. So again, a really 4CN curve, so double major with a lumbar curve bigger than the thoracic curve. And in this case, really her pain was limited to left-sided L5 radicular pain. So this fractional curve is what was painful for her. And what I ended up doing, rather than fusing the entire length of her spine, which would have happened in her adolescence, was just deal with the symptomatic bit at the bottom. And I think Serena is going to talk about this tomorrow, is when can you just treat the, when could you do less for deformity? And she was able to get back to playing volleyball and be very active, and she's now more than 10 years after this surgery and has not required revision. So I think there are lots of examples of patients who really ought to be left into adulthood. Here's another example of a patient who felt very guilty about the fact that, or whose mother, she's now 32 years old, her mother felt guilty about the fact that she didn't have surgery as an adolescent. At this time, 32 years old, she had some moderate thoracolumbar pain. She was active in hiking, yoga, didn't take any pain medicines, and I suggested no surgery. She ended up getting surgery somewhere else and had a isolated thoracic fusion, continued to have pain in the lumbar spine, so now she's 33 years old, ends up with a fusion from T2 down to the sacrum. And that I would suggest is perhaps one of the worst outcomes you could have. So now she's got a deformity, a non-union, and she's fused from the upper thoracic spine down to the sacrum. So this is a subset of people who I think oftentimes treating these people non-operatively is a better option. She ended up breaking her rods and came back to see me, so I ended up fixing her rods and getting her realigned in both planes. But I think overall, there's a lot of role for non-operative care in patients. Just because they have a curve, it doesn't need to be fused. And the final point I'll make is just reiterating something Serena said is, well, what about the future? And our partner, Mohammed Diab, is really one of the innovators in this area. Here's a patient, again, with a 3C curve. And what about new technologies? And he approached this with the tethering of the thoracic and lumbar curve, so motion-preserving type of an option. And I think the role for this still remains to be determined. But overall, what I wanted to emphasize here in a forum that involves both adult and pediatric discussion, I think it's important to have people who treat adults and children together. And I think that the timing of surgery requires a lot of information about the natural history and the expectations. I think early surgery is appropriate for patients with early onset deformity. We heard about that earlier. For patients with syndromic and neuromuscular problems. I think dysplastic spondylolisthesis is a good example for early surgery. But I think we really ought to consider delayed surgery for a lot of the late onset scoliosis cases, especially the type 1A, 1B deformities, some of the structural lumbar curves or 4C and our 6C patterns, and also for smaller thoracic curves. So thanks for the opportunity for offering that perspective. And Lionel, I'm going to look to you and Lee and Kyle in terms of our timing. We had several cases to do, or do you want to go straight to the break or do cases?
I think, why don't we do a couple questions for you, and then we'll move to some cases before the break. We'll plan a break at 10 a.m.
Perfect. So maybe I'll ask if there's any questions, and then we'll put together a selection of cases. All right, thanks.
Hey, thanks. That was a great talk.
Great talk earlier, thanks.
Do you think about the thoracic curves and the Lenke 5 thoracolumbar curves differently? Because as a pediatric doctor, I'm not fussed about a selective thoracic fusion. I think those kids do great, but before there were sort of motion-sparing technologies available, I always felt sick in my stomach when I was fusing those kids. And I just wonder whether there's not a role for earlier even than 50-degree or 45-degree intervention in some of those curves. Because talking to my adult colleagues, they seem to tell me that the kids with thoracolumbar curves, as they become adults, are more likely to progress than perhaps somebody with an isolated thoracic curve.
Yeah, so let's just to bring everybody who doesn't treat the pediatric population, sort of 5C curve we're talking about, a patient with a structural thoracolumbar curve. And can we do something with that early, because the natural history of that might not be as benign? And I agree. I think in general, the curves seem to be symptomatic into adulthood are more the thoracolumbar and lumbar curves, lumbar-sacral curves, than our solitary or isolated thoracic curves. So the 5C curve, is that something, the curve typically goes from T10 to L3 or T11 to L4. So can we do something early with that, or might motion preservation be an option for that? And I agree that that's a curve pattern that I really favor an anterior approach on that. I think in general, I can save a level when I go anteriorly. So typically, I'll do like a T11 to L3 as a disciple of John Hall and David Bradford and Serena as well. We talked about doing shorter segment fusions, sometimes even overcorrecting. And that is a curve that's a lot easier to deal with early on. So in a patient who's really got an oblique L4, I think that's a relatively, that's a deformity pattern that can have a poor natural history. So I would agree with that, treating that early. And as you saw, one of my partners, Mohammed Diab, now is actually doing a lot of those with tethering from the front. And the trouble with the tether on that is that it's a little bit kyphogenic, as Serena pointed out as well. And I'm almost wondering if a posterior tether might be even a more appropriate approach. I think Lionel and I have talked about that a little bit. But I think treating the subset of patients with a really tilted L3 or L4 early probably does make sense.
Yeah, with the thoracolumbar tethers, I hate how the x-rays look on the lateral afterwards, and I take solace in the fact that it's going to break eventually.
Right.
And hopefully their growth has been modified because you're putting them in early enough. But.
Yeah, and to me, going anteriorly is, if I can stop at L3, I go anteriorly. If I can't stop at L3, I'm probably going to do it from the back. Yeah, please.
Yeah, as I was listening to Graham and Serena, you were talking about selective fusion and technology tethering. What are sort of challenges or gaps in adopting tethering and the percentage of growth towards tethering and current technologies, and what might be needed to help faster adoption or better adoption of tethering in those cases?
Yeah, great question. And, so what are some of the barriers to adopting tethering? And I think, well, first of all, is quite honestly, comfort with anterior surgery. I think fewer and fewer people are comfortable with anterior surgery. A lot of this started in Amir Samdami. I had the opportunity to review all of his cases, which are terrific results, by the way, overall. But thoracoscopic approaches, I think there's few surgeons who are really comfortable with the thoracoscopic approach or thoracolumbar approach across a diaphragm. I think that's part of the adoption trouble. I think the fact that the benefit over fusion really hasn't been clearly demonstrated. We're seeing a lot of rod breakages, or I should say tether breakages, some instances of loss of correction. And with the fusion surgery, the instance for revision surgery is actually a little bit lower. Peter Newton showed getting a definitive fusion in the first place gives us a little bit lower rate of revision. And then the incremental benefit of motion preservation really hasn't been demonstrated in terms of any function or pain assessment. But I don't know, maybe Serena, you address this, or any other thoughts about why else tethering might not be as popular as it is? Yeah, it's catching a patient at the right stage of growth, right?
This was also alluded to, just because they show up at a certain point on the growth chart or on their Sanders scale, they don't all predictably grow the same way. So, we either overcorrect them, undercorrect them, and I think we also try to get away with it because patients don't want a fusion, and I think that's part of the problem. I mean, I think the anterior is part. I'd rather do my own anterior approach for those, but I think there are a lot of people, so having a thoracic surgeon have to be there, that adds kind of a level of scheduling complexity. But I think the biggest thing is that we don't yet know the exact patients that, patients are willing to do it because they don't want a fusion, but I'm not sure if that's necessarily the reason that we should do it.
Yeah, having some better prediction of growth remaining, I think, would be a really valuable asset to predictive modeling for that.
I think another aspect of it is that the bar is in the thoracic spine. The bar is fairly high. A selective thoracic fusion, you can have someone go out and be a collegiate swimmer after a T3 to T12 fusion. And so, although I think tethering is a great option, the predictability is nowhere close to what we get with a well-planned, well-executed selective thoracic fusion, and the morbidity of a 9-level fusion in the thoracic spine is not super high. I think that's one of the issues.
Yeah, I agree completely, and that gets the issue of revision surgery, right? So Newton showed that the revision surgery was higher in the patients who were tethered, right?
And very morbid when you're going revision in the chest compared to a revision posteriorly.
But I think we have to be super selective. There's a very small segment of patients that are appropriate for tethering, and it's going to be massive to
And I actually had the opportunity with John Emmons to review the tethering study that Zimmer sponsored, and so I was part of the Data Safety Monitoring Board, and actually the revisions were relatively small and few. I thought the results certainly supported the outcome in that study at least.